most likely diagnosis. My part, I'm going to talk about the clinical presentation or the clinical context. So this patient has anemia which can result from nutritional deficiencies, chronic disease or blood diseases. Hemoglobinopathy, high performance liquid chromatography, which is HPLC, was performed. HPLC separates hemoglobin types based on retention time, allowing us to detect abnormal variants or imbalances in globin chain production. This test is useful in diagnosing conditions like sickle cell disease or thalassemia. So right now, I'm going to pass to the next person to talk about the result.
So next, I will be talking about one of these patients' HbA1c results, which is HbA2 level. So for these patients, HbA2 level is elevated to 5.2%. So normally HbA2 should be between 2 to 3%. So when anyone have higher HbA2, like higher than 3.5, this strongly suggests beta thalassemia trait. So this happens because there is a problem in the beta globin gene. So the body produces more of the delta chains, which form HbA2. So patients with beta thalassemia trait usually have mild anemia, but no serious or strong symptoms.
In this case, the fetal hemoglobin, which can be referred to as HbF, is at 1%. Typically, in a normal healthy adult, the range would lie as less than 1%. The reason for this slight increase is that their patient is suffering from beta thalassemia trait, in that the body tries to compensate for the reduced beta globin chains by making more fetal hemoglobin. This can explain why there is an increase in HbF.
Next is the absence of abnormal variant. Another important observation is the absence of abnormal hemoglobin variant like hemoglobin S, hemoglobin E, or hemoglobin C. This helps narrow the diagnosis. For example, if hemoglobin S were present, we consider sickle cell disease or trait. If hemoglobin E were present, we think about hemoglobin E-related thalassemia. The absence of this variant confirms that the anemia is not due to a structural hemoglobinopathy, but rather a quantitative defect in globin chain production, specifically beta globin. This reinforces the diagnosis of beta thalassemia trait, which is a production issues and not a structural mutation.
Next, I will be talking about the genetic and the public implication of beta thalassemia minor trait. Generally, beta thalassemia minor trait is an autosomal recessive inheritance disorder, which means carriers are usually healthy and asymptomatic and may have mild anemia. But the key concern is, if both parents are carriers, each child has a 25% chance of having beta thalassemia major, which is a severe anemia disorder leading to a lifelong need of transfusion. So from a public health perspective, screening carriers are important. Tests like HPLC are used in prenatal and antenatal programs, especially in regions where these kind of disease are common. Genetic counseling is also important, and it helps families in understanding the risk and make informed decisions about having children.
Putting all the evidence together, the patient's HPLC profile reveals a markedly elevated HbA2 at 5.2%, a mildly increased HbF at 1.0%, and no abnormal variants such as HbS or Hb. Clinically, this matches the presentation of anemia and point clearly to beta thalassemia trait, a condition caused by reduced beta globin synthesis that forces the body to compensate by producing more delta and gamma globin chain. This explains the rise in HbA2 and HbF, while the absence of structural variants rules out other hemoglobinopathies like sickle cell disease. If two carriers have children, there is significant risk of severe thalassemia major, a life-threatening disease requiring lifelong transfusion. In summary, the integration of lab finding with clinical context confirm beta thalassemia trait has the most likely diagnosis, highlight the importance of accurate biochemical interpretation. Not only the patient's care, but also the preventing serious outcomes in future generations.